Hello and welcome to another episode of the SITREP. Today we are discussing weight loss options with bariatric surgery, the different types of surgeries available, requirements for the surgery, and much more. But before we dive into that, please do me a favor and hit that like button and subscribe so you don't miss out on future episodes of the SITREP.
Today's guest is a general surgeon who specializes in minimally invasive surgery and anti-reflux procedures. She's an instructor at the Harvard Medical School and the chief of bariatric surgery at VA Boston Healthcare System. Dr. Ann Smith, welcome back to the SITREP.
Thank you so much. I'm really excited to be back here and really looking forward to our conversation today.
So let's get right into this. First and foremost, in general terms, what are we talking about when we say bariatric surgery?
So bariatric surgery encompasses a number of procedures, but their purpose is to make the stomach smaller. And we now understand that these operations give us an endocrine result in affecting your metabolic outcomes. So we know that the GI hormones, for example, that help you to feel full or that make you feel hungry are impacted by these operations, and they are playing a large role in why these procedures are effective.
Okay, so then knowing all that, why would a person choose to have bariatric surgery? What are the factors that go into that decision?
A lot of people start getting interested in bariatric surgery because they get really tired of the yo-yo dieting cycle.
Okay.
People can be very disciplined. They will eat small volumes of food, they'll do a lot of exercise, and they'll lose weight. And that's great. But many people, and the majority of people, find that very hard to maintain. So either it's a lifestyle modification and they can't maintain it, or they lose enough weight to the point that their body starts to revolt. They start getting these signals that they're really hungry, and it's hard to resist, and they go back to eating more and often will regain all of the weight that they've lost, plus more on top of that. This produces this cycle where they try again, they lose weight again, and what happens is that the weight slowly creeps up because they keep regaining the weight, and it's very frustrating. And the reason that it happens is because your body was built to prevent you from starving to death. And many people are just really struggle with that balance. Another reason that people get interested in bariatric surgery is because they have medical problems that are related to obesity. I'm thinking of things like sleep apnea, high blood pressure, diabetes. These health problems really decrease your quality of life, and bariatric surgery is known to have a dramatic impact on these. In fact, we can see people have complete reversal of diabetes. They can get off all of their blood pressure medications. Most people don't get off all of their medications, but many get off a very significant amount of their medications. Many people have reversal of their sleep apnea, and that produces an incredible improvement in quality of life, not to mention increasing your longevity.
I'm a veteran, Mike's a veteran. We get our service here at the VA, and we're happy with it. How is that going to compare to what I would get out in town?
What you're going to get at the VA is going to be very comparable to what you get out of town. We have the exact same structure that people have outside the VA. So the way that it works is you start with an info session if you express interest to your primary care doctor about bariatric surgery. The info session will give you a lot of information about bariatric surgery. People might be watching this podcast because they're getting ready for their info session. Once they attend the info session and have a chance to ask a lot of questions, then they will be referred to the bariatrician. The bariatrician is the doctor who's going to go over your entire medical and surgical history, look at all of the medications you're on, and talk to you about what you're getting yourself into, making sure that this is something that you're ready for, because it's a big change. It's a big change not only in improving your health outcomes, but it also is a big change in behavior and lifestyle. If that all goes well, the bariatrician is going to give you a checklist that you need to complete. Things like getting an abdominal ultrasound or an EKG and getting your nutrition labs. While you're doing those things, then you're also starting your visits with the bariatric psychologist and the bariatric nutritionist. These are really important in preparing you for long-term success after bariatric surgery. The psychologist is going to talk to you about what it's going to be like after you have this surgery that's going to limit how much food you can eat. Eating is just one of the most social things that we do. And it comes up all the time. It comes up in holidays. It comes up if your neighborhood is having a block party. It's just all the time. And you need to be able to know how to handle these situations so that you can be successful and also live a vibrant, happy life with your friends. The bariatric psychologist is also going to screen you for any kind of eating disorders like binge eating or anorexia that might prevent you from being really successful with bariatric surgery, and then would get those treated before you could go on. Simultaneously, you'll start working with the bariatric nutritionist. The bariatric nutritionist is going to train you to keep food logs so that you have a better understanding of what you're eating and how it affects how you feel. They're going to teach you about proteins, carbohydrates, and fats. You might learn that your body has a really big fluctuation in blood sugar and makes you feel bad when you eat more carbohydrates. And that if you eat a higher protein diet, that will even out your blood sugar, make you feel better, decrease the amount of muscle mass that you lose when you're actually losing weight from bariatric surgery, and all in all keep you in a healthier state. So these are the kinds of things that bariatric nutritionist is going to work with you on. And you'll have at least 3 visits with them, keeping your food logs, before anybody clears you to be ready for bariatric surgery. And the whole process from the beginning to the end usually takes an average of 6 months. If you have a lot of medical problems, it might take you longer than that. If you're a really healthy, younger person, you might be able to get through in less time, but 6 months is the average. Once you clear these important visits, then you meet with the bariatric surgeon, either myself or one of my bariatric surgery partners. And then we go over everything that's been done. We go over all your testing. We go over your entire medical history, and then we plan together with the patient for what bariatric surgery is going to best serve that person. And then if they've met all of the testing that we needed them to do, then we book them for surgery.
So it's a team approach. I mean, I've got a whole team working with me. It's not just one person at all.
That's really right. It's multiple programs that are participating in this interdisciplinary process to get each person to be the healthiest person that they can be at the end.
That's great.
And once the surgery is done, you continue with this team, I would assume? It's not just
That's
like,
right.
hey, you had your surgery, congratulations, good luck?
No, we follow the standard of care where we follow our patients out for 5 years. So when a patient joins the bariatric surgery program, they're really joining a care team that is going to shepherd them along and make sure that they're going to be successful long term. We really monitor patients' nutrition labs. We follow everybody's obesity-related medical problems. We make sure that we know what medications everybody's on for those medical problems, and then we really delight in seeing those medications go away after surgery, and we keep track of all of that.
Okay, so I guess I've heard a lot about, why you should choose bariatric surgery. One of the big issues always seems to come up is better life expectancy, increase in life expectancy. Is that true? And if so, how does it work?
That is true. I'm so glad that you asked this. Bariatric surgery is the only weight loss method that we know of, whether you're talking about diet and exercise, weight loss medications, pills or injectables, or surgery, obviously, that has been proven to increase life expectancy long term. And we have multiple studies that show this. There was a study out of Sweden that followed bariatric surgery patients for over 20 years. They have a 99% follow-up rate. And they found that when they compared patients that had bariatric surgery to obese patients who didn't have bariatric surgery, the patients who had surgery are outliving their peers by over 3 years. We've also done a study on veterans following patients out long-term, and we have seen even better results where patients get a more than 10% life expectancy increase in 10 years.
So I'm ready. Sign me up. I'm going. What's my process now? How is this all going to work out?
So I explained about how the info session works, and then you see the bariatrician, then you see the psychologist and the nutritionist, and then you see the surgical team, myself or one of the other surgeons. After that, we expect you to stay in the hospital for 2 nights. And we do this for the important reason that we want to make sure you're going to go home and really thrive. I have a lot of patients who come from far away. And so I don't want to send them out the door only to have them come back and say, wow, I'm dehydrated. So we keep everybody for 2 nights for that reason. We slowly progress people's diet. And by the time they go home, they should be tolerating protein shakes and they should be tolerating clear liquids very well. They stay on that diet for 3 weeks, and then they meet again with me or one of my partners, and they meet with a bariatric nutritionist, and they learn how to slowly advance their diet. So then they progress to be able to eat pureed foods, and they'll do that for a period of weeks until they can progress to soft foods. And by the time we see them at 3 months after surgery, then they're advancing to a regular healthy diet for the rest of their life. We see everybody for about every 6 months after that for 2 years. And at the 2-year mark, then we start just checking in with people once a year. But we follow people out to 5 years before we place them safely back into the hands of their primary care doctor.
Now, okay, so as Jim said, I've made the decision I want to do this, but my understanding is there's multiple types of bariatric surgery. How do I decide which one, and which ones does the VA support if I'm a veteran and want to do it through the VA?
Yeah, this is a great question. So we offer the 2 most popular bariatric surgery operations in the United States, the vertical sleeve gastrectomy and the Roux-en-Y gastric bypass. The reason that we offer these 2 operations is because together they serve a very broad population of patients with different medical needs, and they also produce great outcomes with what we think is minimal to acceptable amounts of risk. So let me talk first about the sleeve gastrectomy. People like this operation because it's easy to understand. Your stomach is shaped kind of like a big floppy wine cask. And the sleeve gastrectomy takes the floppy part of the stomach and shaves it off. We pull it out of the body. Because that part of the stomach is removed, this is not a reversible operation. But that's okay. This is an operation that has great outcomes and very few complications. People do well with this operation because there are fewer risks with malnutrition. There are no new connections in your intestines where you could have problems. And it's also a more forgiving operation. You have a little bit more stomach lining, so you can go on to take a wider variety of medications afterwards. Also, if you take any medications where we have to follow your blood levels, things like warfarin, also called Coumadin, or there are numerous psychiatric medications like lamotrigine or Keppra. All of these medications require blood level checks. Those medications are better understood in terms of how they're absorbed after a sleeve gastrectomy. So if patients are on those, this is a better operation for them. The long-term outcomes for the sleeve gastrectomy are terrific. We get great reversal of diabetes. Patients lose an average of 8 to 12 body mass index points on it, or you could say somewhere between 15 to 30% of excess body weight loss. That's what you need in order to reverse the common obesity-related medical problems like sleep apnea, diabetes, and high blood pressure. The things that we worry about long-term after a sleeve gastrectomy are primarily reflux. For patients who come to us without any reflux and have the sleeve, 60% will go on to develop reflux.
60?
60, yeah, wow. It's a pretty high percent. Almost all of these patients can be managed by taking omeprazole. So we think of that as a reasonable thing to have to take on for the incredible health benefits that you gain, like the increased life expectancy. And we haven't even talked about the decreased cancer rates yet. The other operation that we offer is the Roux-en-Y gastric bypass. People like this operation, especially if they have reflux coming into it, because this is the gold standard both for bariatric surgery as well as for reflux. This is an operation where we cut a small pouch out of the stomach, and then we bring up a piece of small intestine and connect it to that pouch so that when you eat, the food comes down your esophagus into the small stomach pouch and then out through the small intestine. It completely bypasses the majority of your stomach. It's also bypassing the beginning of your small intestine. This is where all the digestive juices are coming from your liver and your pancreas. Those digestive juices are diverted pretty far downstream so that the food that you eat doesn't actually mix with these digestive juices until 80 to 110 centimeters after your stomach. We used to think that that was really a malabsorptive operation, but now we know that really in the long term, your body ends up absorbing all those calories that you eat. We think that this diversion of these digestive juices, though, is playing a really significant role in people's appetite and the kinds of foods that you're interested in eating. We noticed with both of these operations that people have a real improvement in how hungry they feel. They feel full after they eat, and they stop craving a lot of these sugary foods. And we think that's part of the reason why. The Roux-en-Y gastric bypass helps with reflux because it makes your stomach really small. And bile, which is coming from the liver, can't backwash anymore up your esophagus because it's been disconnected. Another reason that people really feel comfortable with the gastric bypass is that this is a reversible operation. Because we leave the rest of your stomach in place, we can reverse you. Now, we don't do that commonly, and it's a higher risk procedure and not something that we would do lightly, but it's possible. The Roux-en-Y gastric bypass does have a higher risk of long-term complications, and these tend to happen where the small intestine meets that stomach pouch, because the small intestine lining was really never designed to see the things that are coming out of the stomach. That small stomach still produces a small amount of acid. So you can get ulcers right there where the small intestine meets the stomach. Those are called marginal ulcers. They can be very painful. They can even perforate. Yeah, it's an operation that you have to take very seriously. And it's the kind of operation that you want to really be engaged with the medical system if you're going to have it. But it has great outcomes. It has even slightly better outcomes than the sleeve gastrectomy in terms of reversal of diabetes. It has slightly more weight loss. People lose between 10 to 15 body mass index points instead of 8 to 12, like we expect with the sleeve. And if you have bad reflux, then it's a good choice. But the other thing to know about the gastric bypass is that when we take that piece of small intestine and bring it up to the stomach pouch, we're creating this internal bridge that didn't used to be there. And because of that, there's a space. There actually are two spaces where the small intestines can sneak under and actually get stuck. That's called an internal hernia. So I just want anybody who's thinking about having the gastric bypass to know that if you decide to have a gastric bypass and you go on to develop severe abdominal pain, an internal hernia could be the cause, and that can be life-threatening. You have to get yourself to a bariatric surgery center and have a CT scan to make sure that you're safe.
Oh, okay.
It's a lot to that.
It's a lot to think about as far as... So how would you make that decision? I mean, I'm assuming as a layperson, then I would rely heavily on your guidance as far as which one would be better for me versus the other. Is that true, or is it totally up to me?
That's fairly true. I do tend to shepherd people into a choice that I think is a really good and safe choice that will serve them well long term. I think about patients' medical history. I think about what kind of access to care they have. But I'm largely considering what medications they're on. If this is a person who comes to me having taken ibuprofen forever, I'm really going to try and give them a sleeve gastrectomy because you can't ever take ibuprofen again if you have a gastric bypass. The reason for that is that it can cause marginal ulcers. And there are 3 things that cause marginal ulcers: smoking, ibuprofen, or any products like it that are called NSAIDs. That's ibuprofen, Advil, Motrin, Aleve, naproxen, meloxicam. And you also can't ever take prednisone again. Those all cause marginal ulcers. So if you're an asthmatic who periodically has to take prednisone for asthma flares, gastric bypass is not a good choice for you.
Okay.
But a lot of people are coming to talk to me with a lot of experience. Maybe their relative has already had a particular procedure and done well, or they had a particular procedure and didn't do well and they don't want that one. So a lot of people have history that we have to account for, and we make the decision together in a way that I think will best serve the patient.
Physically, it sounds like a lot. I mean, it sounds like a lot of demands there, but that's not all of it. There's got to be other support pieces to this, like emotional and mental. And so if you'd speak to that, please.
That's right. We really want anybody who's going to have bariatric surgery to have a emotional support team around them. And sometimes that's your family, sometimes that's your friends, sometimes it's a mix of both. But this is, like I said, treating a very social issue, which is eating. And I need your family and friends to really be on your team and cheering for you, because you're going to be eating differently when you sit down with these folks. So engaging your family in a conversation about bariatric surgery is really productive. This is something that I think people have a hard time with, because just bringing it up out of the blue seems like kind of a non sequitur. But the truth is that just like patients know that they're obese, their family also know that they're obese. And so bringing it up actually might be a major relief to your friends and family. Your friends and family, they want you to be healthy. They want you to be able to lose weight and keep it off. And speaking to that with them can help get that conversation going. When I am coaching patients into how to talk to their families, I remind them to say, I'm looking to get healthier. I want to lose this weight. I want my medical problems to get better. And I know that bariatric surgery is a very successful process that requires a lot from me, but will give me the health outcomes that I want. It is known to reduce cancer rates, especially hormonally related cancers like prostate, breast, and ovarian. It is known to increase life expectancy by at least 3 years. I want an increased quality of life. I want to be able to get down on the floor and play with my grandchildren, children. I want to be able to go outside and go for walks and not be so hot in the summer. There's just such a laundry list of health improvements that come with this, and quality of life improvements that come, that it's really worth having that conversation with your friends and family. They also need to be there for you after surgery. We really want you to have a support person after surgery who can watch out for you and make sure that you don't get dehydrated. Make sure that you have all the protein shakes that you need. And if you look like you're getting sick, they can call the doctor for you. So this support team is so important on so many levels for a long time.
You touched on like the social aspects and the big changes. One thing you didn't mention is, okay, in those social situations, what about alcohol? How does this affect your ability to drink alcohol? Should you not drink alcohol? Since that is obvious, along with food, is also a very big social, engagement.
It is. Alcohol is such a social thing in our country. And unfortunately, it's just not very nutritious. It also has some judgment-changing impacts. So we actually really require people not to drink any alcohol before surgery, and we insist on that for at least 3 months before surgery. If we think that you're drinking alcohol, we reserve the right to test you. But I really want patients to think about this. When you drink alcohol, even if you're just having 1 glass of alcohol, after you drink 1 glass of alcohol, then the second glass of alcohol sounds like it's really just not that bad of an idea.
Right.
And this can escalate. You can consume an incredible number of calories this way. But also, once you start drinking alcohol, then you're also snacking, and it just snowballs into this unhealthy process.
Things go hand in hand after a while.
Yeah. Additionally, a lot of times when people drink, they also smoke, which is also not healthy for you. So, there's really nothing nutritious about drinking alcohol. It has a lot of calories, and it produces all these behaviors that are not good for your health. So we just have a policy of no alcohol, not for at least 3 months before surgery. And I really don't want people to drink afterwards for all these same reasons. I understand that many people will go on to have a glass of alcohol, but honestly, when I see people come back with weight recurrence, alcohol is a very common theme in that.
So you mentioned earlier about a support, around you when the stuff is happening. Do you converse with the families? Do you counsel the family prior to or after about how to handle that with the patient? Sometimes I do. If patients give me the opportunity to talk to family members, I'm very glad to. Some people will bring their life partner into the early conversations. A lot of people will have family visiting afterwards, and then I'm glad to talk to them. For anybody who's having trouble bringing this up to their family, or who has a family or friend that's not very supportive, I'm absolutely willing to talk to these folks for you. But
but I would say it doesn't happen a lot. I think part of that is because our program is 100% remote. So I think that's part of why I do have a large population that travel from far away. We see everybody by video, unless people want to come in face-to-face, which they're more than welcome to. But almost everybody chooses to meet with us by video. And that is less conducive to these conversations.
So you talked about a little bit earlier, I've been through all my testing and counseling. I've made the decision. I've met with you. And now it's my day. It's surgery day. Walk me through that. How does the actual surgery work, take place? What should I expect?
Yeah, first I want you to know that you should expect really professional, friendly people who are going to greet you. You are going to be seen in the preoperative holding area. That's where you're going to get put on the hospital gown. Your things that you brought with you for your hospital stay are going to be taken and packaged for you. And you're going to start meeting members of the surgery team, the nursing team, and the anesthesia team. When we're ready for you and your operating room's almost ready to go, you're going to be brought up to a different room where all the final checks are going to be made. Everybody's going to make sure that you are who we think you are, that we're doing the operation that you say. You're going to be asked for your medical record number and your birthday about 500 times. But you're really going to get to meet everybody that you're going to see in the operating room beforehand. Then you're going to roll back to the operating room. You're going to be working with a team of nurses that's very used to handling bariatric patients. They're going to make sure that they keep you safe. They're going to make sure that they keep you warm because the operating room's a little bit cold. When you get back to the operating room, you're going to see a lot of equipment and a lot of people. But all the people are people that you've already met, members of the anesthesia, surgery, and nursing teams. You'll probably be in an operating room with a surgical robot because we often do these operations robotically. Once we get you on the operating room bed, then we do a final safety check. And then you go off to sleep. By the time you wake up, your bariatric surgery is going to be done. And we do these operations all minimally invasively. So everybody ends up with about 5 small incisions. The biggest incision is the width of my thumb, and the others are usually about the width of my pointer finger. So very small incisions. Post-operative pain is usually not a big issue. Surgery depends on which operation you're having. If you're having a sleeve gastrectomy, it's probably going to take around 2 hours or less. If you're having a gastric bypass, it's probably going to take around 4 hours. And then you get out of the surgery and you're in the recovery room. And when you wake up, you're going to have a nurse who's there taking care of you, checking on your pain control, making sure that you're not feeling nauseous. And they're going to start getting you on some sips of liquids. By the time you're ready, you're going to go into your room where you'll be for the next 2 days. Then you're going to meet your new nurse. That's going to be your floor nurse during your recovery period. And they're going to give you a stack of medicine cups about this tall on your table. We use those medicine cups to help you to understand how much fluid you're supposed to be drinking. And you're going to get to drink 1 medicine cup every 15 minutes. That helps patients to understand and not overdo it. People need to know that if they do overfill, they can end up vomiting, and that does not feel good.
Oh, I bet.
So we use these small medicine cups to help people self-regulate 1 medicine cup every 15 minutes. We expect patients to be up and walking. It is a little sore to get out of bed, but it makes you feel more human once you stand on your own 2 feet. And then you can just shuffle out the door, down the hall, just get out of your room. We keep you for 2 nights, and the first day after surgery, that's when we start you on the protein shakes. And as long as that goes well, then by the second day after surgery, you get to go home.
We understand what's going to happen now. You're going in and it's all done. I'm checked out. So what's my recovery time like after that? Am I off my feet for months, weeks, days, hours? Is it?
It's interesting. Bariatric surgery recovery ends up being very different than usual laparoscopic abdominal surgery. After abdominal surgery, in general, patients often report being really tired. They are just kind of hanging out at home. Bariatric surgery patients are totally different. Many people report this new surge in energy, and I think that it's part of the endocrine process where your body is mobilizing a lot of the energy that patients have stored for so long. And I've had many patients tell me that they feel like a caged tiger, and they just want to get out and they want to be walking. And so I encourage people to start doing physical activity. But, at first, it's good to be an underachiever because we don't want you to go out for a walk and discover it's too hard and too exhausting to get home. So baby steps, but slowly progress. They're going to be taking this liquid diet for the first 3 weeks after surgery. And it kind of depends on what people do for work in terms of what kind of advice that I give them. If you're working in a warehouse and you're lifting heavy things, going back to work right away is not going to work. You need to be at home, making sure that you're staying hydrated. Staying hydrated after this operation is like a job. You're not always taking these medicine cups every 15 minutes. You are eventually able to drink a little more and then a little more so that it's easier to hydrate. But that process takes 2 to 3 weeks to really get it down so it's not so burdensome. And some people will be tired and will need to take naps in the afternoon. And that's totally normal too. So I generally encourage patients to take 2 to 3 weeks off from work if they're able to.
And if it's a labor-intensive job, longer than that?
If it's a labor-intensive job, we do encourage people to take off longer than that. There's old advice, and you might see this on an old podcast, where we used to say you can't lift anything heavy for 6 to 8 weeks after surgery. And the goal with that advice was to prevent people from getting a hernia at the larger incision site, the one that's the width of my thumb. But looking at the literature shows that this is not really supported. So now we advise people that if you feel like you're up to doing something, then it's okay to do it, but just proceed with caution.
Know your limits. All right.
Yeah.
What are my expectations for weight loss? If I follow, what you've told me and, I start to get out and walk and do some exercise, with both types, what's a reasonable expectation, I guess, for weight loss for myself? And how long do I lose weight for? Like, a few months, or how does this whole process work?
Yeah, great questions. So for the sleeve gastrectomy, I generally tell people to expect between 8 to 12 body mass index points. And for the gastric bypass, I tell people to expect between 10 to 15 body mass index points lost. Many people have no idea how many body mass index, or what their body mass index even is. But it's the best I can do when I'm dealing with people who are anywhere from 4'9" to 7'1". The weight they're going to lose is going to be pretty different. And it's more generalizable this way. Another way you can think about it is what your excess body weight is. So many patients who are obese have already heard from their primary care doctors a million times that they need to eat less and exercise more. And some people will have some idea as to what their ideal body weight is. So compared to the weight that they are, that ideal body weight, that's the excess body weight. And what we find is that the majority of patients will lose somewhere between 10 to 30% of their excess body weight. What you need to improve your health outcomes is usually somewhere between 10 to 20% of excess body weight, or 15 to 20% of excess body weight. If you can lose that percent, you're going to get a great improvement in the obesity-related medical problems that you already have. For those patients who are starting at the much higher end of the scale, I've treated patients with a BMI of 70 before, 60s. My observation is that those patients tend to lose more than the patients who are starting at the lower end of the scale. I think the body, from an endocrine perspective, is willing to tolerate more loss. But that's what I see. So if you're starting with a body mass index of 35, you're going to lose a little bit less on that in this range that we give you. But your health outcomes should mirror the health outcomes of any patient. It takes a while to lose all this weight. So I think the majority of the weight comes off in the first 6 months, but people will keep losing weight sometimes up to 2 years out. That's the longest I've ever seen, but I would say people start to hit their plateau usually around 9 months. It's a little bit different for everybody. That was going to be my follow-up
to you. At some point, your body just says you've done enough.
That's right.
And no matter how well you're eating or how much you're exercising, you've had enough.
That's right. And your body is also attuned to what your health needs are. If you've lost this incredible amount of weight, 8 to 12 body mass index points, let me congratulate you. You have made incredible improvements for your body's health. You're going to have those gains in life expectancy. You're going to have those decreased cancer risks. And it's wonderful. When we talk to patients about their weight, or we really have to incorporate what their journey has been. If they're 300 pounds, but they started at 600 pounds, like, wow, great job. I think in those cases, people can get a little bit fixated on numbers rather than keeping the perspective of what your health gains have been. And that's why it can be helpful to have the bariatric surgery team involved in your care, because we can help the rest of your doctors keep perspective on what your weight means for you. If you've traveled this journey and lost this weight, you did great.
So I've gotten my care, I've done the procedure, and I'm moving on now. There's going to be follow-ups, I assume. Am I going? And you talked about being remote, a lot of this. How am I going to get that follow? Am I going to need to come to you every time there's an appointment now, or is there other options for me?
No, the only time you ever have to come to our hospital is the day of surgery, as long as everything goes smoothly, which is the usual way. All of your follow-up visits can be by video. Oh. So we really have a video-based practice. This does mean that you have to go get your labs drawn at your local hospital, but fortunately we have remote access for all of our hospital system, and we're able to put those lab orders in without having to bother your primary care doctor for them. So it's a video-based assessment unless we have some concerns. We see patients at 3 weeks out from surgery, 3 months, 6 months, and then a year. Then we see people for another 6 months, up to the 2-year visit. And after that, we see people annually going out to 5 years. So we follow our patients for a long time. We want to make sure that everybody's health outcomes are excellent, that you're getting the long-term care that you need, because there are some long-term care issues. And then once you're stable and you're doing weight and your health is good, then we put you back in the hands of your primary care doctors. This program has been running since 2009, so the primary care doctors now have gotten used to receiving their bariatric patients back. They know what labs to order, and we also send sign-out letters to all the primary cares when we're able to release patients from our program, so that they know they need an upper endoscopy every 3 years if they had a sleeve gastrectomy, and they know what labs to order every year for them.
So you talked about body reset. Part of that body reset is a little bit of weight gain normal. As long as I'm continuing to eat healthy, and if I see some weight gain, is that normal? Should I be concerned?
I would say a weight regain of like 5 pounds, totally normal.
Okay.
A weight regain of 10 pounds, then you're starting to edge towards weight recurrence. I have seen various definitions of what weight recurrence can be. Sometimes people define it as a 5% regain of the weight that's lost. But I think that's not that practical. If somebody loses 100 pounds and then regains 5 pounds, that's 5% of what they lost. And I think that a 5% weight fluctuation is normal and healthy. You ought to be able to have Thanksgiving dinner with your family and have your weight go up, and then continue to eat healthy and let it come back down naturally. So I try and just keep track of patients when they are worried about weight recurrence. If you have a weight regain of 20 pounds, I'm calling that weight recurrence. Really, once you creep over like the 10 pound limit, then I start to call that weight recurrence. And usually that sparks a conversation with the patient. The patient usually brings it up on their own, but I'll bring it up if they don't. And then we talk about how to manage that. We have a lot of tools for managing weight recurrence.
Okay, so I understand that there might be some weight gain, and then that's normal to an extent. But what is the reoccurrence rate? You talked a little bit about that. So what do you see, historically with your bariatric patients?
So we've followed patients out long-term. Like I mentioned, the gastric bypass is really the gold standard operation for bariatric surgery. And so we have good long-term data on those patients. We know that patients going out 10 years after gastric bypass, only 3.4% of patients will regain their weight. But that's saying regaining their weight to within 5% of their starting weight. But still, 3.4%, that's a pretty low recurrence rate. For the sleeve gastrectomy, that's a newer operation. It really rose in popularity around 2011 to 2013. it was the first part of an operation that was often staged in two pieces called the duodenal switch. They discovered that you didn't need to do the second stage. The first stage was enough, the sleeve gastrectomy. So looking at patients' outcomes from the sleeve gastrectomy going out 4 years, we actually found a 14% recurrence rate to within 5% of their starting weight. That's a lot higher than the gastric bypass. And sometimes that plays a role in which operation patients want. They're really afraid of weight recurrence, and so they prefer to accept the higher complication risk of gastric bypass and go with that one. But what I counsel my patients in now is that these studies were done before the rise of really effective weight loss medications. We now have these injectable weight loss medications that we are able to use in patients who experience weight recurrence. So if patients are open to taking a lifelong injectable weight loss medication, if they develop weight recurrence, then the sleeve gastrectomy can be a great option for them. It is safer with fewer long-term complications. Just know that you might end up needing this supplemental weight loss medication to keep the weight off. So when patients do experience weight recurrence, then that is a conversation that we have. In order to qualify for weight loss medications, you have to do a number of things. You have to be active with a nutritionist. You have to be living as active a lifestyle as you can. A lot of our patients have experienced injuries from their service, so sometimes can't be that active, but just within the limits of your ability. If we think that you need to work with a bariatric psychologist, then we'll send you to them too. Sometimes people develop binge eating disorders or just behaviors that aren't that conducive to long-term health. In those circumstances, then they need to work with a psychologist. We call that a 360-degree approach to weight loss. Once they are doing that, then we can also offer them weight loss medications, assuming that their body mass index is 30 or higher. If your body mass index is 27.8, then you're safe and healthy, and you don't need weight loss medications, even if you've experienced weight recurrence. But we do follow those patients a little bit more closely if it looks like they're creeping up.
So, okay, you're talking about, and now that you say that, there's been a lot in the news about these weight loss medications. Could they be an alternative to bariatric surgery? Just the medication itself?
Yeah. So there are some important things to understand about the weight loss medications. These new medications, first of all, they are very effective. They're not as effective as bariatric surgery, although tirzepatide, which was just reported on about a year ago and hasn't been FDA approved yet, that almost achieves the same weight loss outcomes that bariatric surgery does. Not quite, but almost. We do know that if you start on these medications, that's a lifelong commitment. If you come off of them, you can expect your weight to come back. We are using these medications for patients who have weight recurrence in bariatric surgery, and some of our patients have come off of the medication and been successful, but for the most part, people just stay on them. In terms of choosing whether you have bariatric surgery or you take these weight loss medications, I don't think that this is these are not contradictory. They can be compatible. You can try one and then try the other. So a reason to choose weight loss medications might be if you just aren't personally ready to have bariatric surgery. As we've talked about, it's a big commitment in terms of behavior, lifestyle modification, and some people just don't want to make those changes. Or if you have an addiction, if you are smoking, if you are using a lot of alcohol, then I still want your health to improve, even if you're struggling with these things. So then weight loss medications can be a good bridge. Weight loss medications, depending on what you're taking, will lose you somewhere between 5 to 20% of your excess body weight. Sometimes that's enough to improve health outcomes. However, the studies that have looked at this have not shown the health outcome improvements that bariatric surgery achieves. That's a little bit puzzling.
Right. So even if you're losing the weight with the medication, so far it doesn't show that the health benefits are as good as the surgery.
It's not reflected in the literature.
Interesting.
However, I think that will change. I have heard at conferences that health outcomes are going to improve in future studies that are coming out, but they're just not out yet.
So in preparing for this now, you've already kind of touched on one of the big three, that being alcohol. What about the other two big vices, caffeine and smoking? Do I have to quit before I have surgery? Do I have to at least be pointed in the right direction? How does all that affect my ability to have bariatric surgery?
So we require patients to quit smoking before they can even start the program. If a patient is actively smoking and a referral comes in, we will decline. So you have to be completely off of any form of tobacco products. You can't be smoking. There's no chewing. There's no vaping. There's no e-cigarettes, nothing. And this is both for your health, but also if you were to have a gastric bypass, it would be completely unsafe. Smoking, we know, causes marginal ulcers, and those ulcers, as I've mentioned, can perforate and kill you. So we can't play around with that. You can't smoke and be in this program. From a caffeine perspective, I have great sympathy for people who love their caffeine, but we really want you to be off of caffeine. We want this for numerous reasons. One is that a lot of caffeine is carbonated. So if you're drinking soda, you're just not going to have any room in your new small stomach for any carbonation. If you drink carbonation, first of all, you're going to burp like crazy, or you're going to be vomiting. And second of all, if you're able to keep that gas down, you won't have any room left for fluid or actual nutritious food. Another reason that we want caffeine out of your life is that all the other forms in which caffeine comes are either abrasive to your stomach in terms of coffee and tea, or they come with a high sugar content. Basically, none of them are good for you. I've actually had patients develop GI bleeds just from a single cup of coffee after a sleeve gastrectomy. So another reason, yet further, that I don't want you drinking coffee or tea is that this ends up being a vehicle for cream and sugar. People take a 2-calorie beverage and they turn it into a 200-calorie beverage by adding sugar, flavorings, creamers. It gets to be a problem really fast. So it's a lot easier for all of these reasons that I've mentioned just to tell people, I need you to get off caffeine. And sometimes that's the hardest challenge that people have. I was about to say,
I mean, this is a huge commitment. I mean, you've basically said people can't drink alcohol, they can't smoke cigarettes, they can't drink any type of caffeine, and they're not going to be able to eat. So what's left? You're talking about you've hit all the vices pretty much.
Delicious protein shakes. No, people are able to get back to food 3 weeks after surgery. They start to have pureed foods. They're able to taste a lot of things that are delicious. But it is a little bit of short-term sacrifice for long-term gain. But we expect your life to dramatically change. I have patients who have not, gotten on public transportation for over a decade because they feel uncomfortable or don't fit. People who cannot get on a plane to go fly to see their family for the same reasons. People who can't ride a bike. I have patients who really struggle to move, and the first time I meet them, they have a walker and or are in a wheelchair and go on to live totally independently. They no longer need these assist devices. They are no longer tortured by always being hungry. They have this positive feedback all the time of people telling them how much healthier they look. But man, it's just so much of a joy to ride a bike if you couldn't do it before.
Sure.
It is a real delightful change in how you live. And yes, it is a little bit of a big ask up front. I want you to stop drinking alcohol. I'm asking you to change a lot of social behaviors. This is how you interact with your friends. I understand. But this is also what got you into a place where your health is impaired. And I want to bring you back. So part of the process of working with the nutritionist and part of the process of working with the psychologist is handling these issues. Like, how are you going to go out and have a good time now with your buddies? This is a really important question. And it affects your long-term happiness, but also it really affects your long-term health.
the things you're going to gain are going to far outweigh what you're giving up, is what we're understanding too. And even you talked about cancer.
Yeah.
Explain that part.
So we found that patients who are able to lose weight with bariatric surgery go from really increased cancer risks to reaching normal cancer risks. The cancer risk improvements that we see the biggest changes in are the hormonally driven cancers. So for men, it's prostate cancer, and for women, it's ovarian and breast and endometrial cancer. But there are improvements in cancers across the board, even colorectal cancer. We see decreased risks. We see decreased risks in pancreatic cancer, all kinds of GI cancers, cancers that have nothing to do with the intestines. You know, a lot of these are surprises that you get improvements in this diverse array of cancers, even skin cancer, your risk decreases. And I think that this is probably because people who are morbidly obese avoid the healthcare system because everything gets blamed on your weight. And true. It's a lot harder to interact with doctors when you're carrying around extra weight, because that's the first thing people talk about. Once you get rid of that weight, it's a lot easier to seek attention because people just feel like they get a better result.
So I'm a veteran. Is there an advantage for me to do my bariatric journey through the VA as compared to going downtown?
There's a huge advantage in doing your bariatric surgery with the VA. First of all, one of the reasons that the VA system is so great is that it holds the records for your providers no matter where you go. So if you're here in New England and you get bariatric surgery, but later on you move to some warmer climate, all your doctors there in the VA are going to be able to see the operative reports. They're going to see all your nutritional labs, and they're going to be able to follow you. Similarly, if you live here in New England where it's cold and you go down to someplace where it's warm for the winter, all your doctors are going to be able to follow you. I'm going to be able to see your labs as we continue to have our 5-year visits going out long term. You're also going to have the wonderful benefits of having it be more affordable because it's part of the VA system. Then there are the additional benefits of just being part of the VA community. So if you're a veteran, we've got bariatric support groups afterwards for people who are like you. You know, a lot of our veterans suffer from PTSD, and that can play a role in bariatric outcomes. And being able to talk about that in support group is just a wonderful feature of part of our system. There are a lot of veterans who suffer from problems that are unique to having served our country, and it's great to be able to work through those as part of the post-bariatric process.
So you've talked a lot about this now, and it has wonderful results. So why don't we see more of it? Why don't, if I'm overweight, why don't more overweight people have bariatric surgery then?
I think that a lot of people who are morbidly obese blame themselves. And that is the culture around obesity, not just in our country, but in a lot of places. We're also really a pull yourself up from your own bootstraps kind of society. And there's a lot about that is great, but when it comes to obesity, it just does not work.
Especially as a veteran, though. I mean,
that's right.
They're taught that from day one, going through whatever branch they were in.
Yeah, and it's such a great mindset for independence and promoting creativity and industrious behavior. But when it comes to the disease of obesity, it does not work. And the reason for that is that this is an endocrine disorder. It is a recognized disease by the World Health Organization. We know that there are numerous GI hormones and other hormones that are involved with this disease process. And we can see that when we treat it as a disease and we address these hormonal problems, people get better. These injectable weight loss medications are GLP-1 receptor agonists. They are treating the hormonal disease of obesity. When we do bariatric surgery, we're taking out or excluding parts of the stomach that are secreting these GI hormones that are so hard to deal with. And that's why it's effective long term. I think people treat bariatric surgery like it's the easy way out or like it's somehow cheating. But what it's actually doing is effectively treating an endocrine disorder. And that's why people get better, and that's why people are able to stay better for the long term. because we are fundamentally changing how your GI hormones work. And we give you great health outcomes. And we improve your long-term life expectancy. And we get you off medications that you're tired of taking. So for the people who are blaming themselves, or for the people who have family members who think this is the easy way out, like, take a look at this disease. This is a real disorder that makes people's lives worse and makes people's health outcomes worse, and it ought to be treated like the disease that it is.
Yeah, that's a great point, because that's not how we look at it in this country. You know, there's a lot more sympathy if somebody's an alcoholic or addicted to drugs, you know, but you're right, when it comes to eating disorders, or it comes to somebody, well, don't eat pizza, you know, go outside and run instead of, you know, having chips. You know, you're right, there's a lot less sympathy for someone who has an eating issue compared to if you're having alcohol, even smoking. You know, there's a lot more sympathy for those folks.
That's right. And I love working with the bariatric population because so many people are so disciplined, and people have just driven their diets down to a very bare bones calorie intake, and they exercise and they just can't get the outcomes that they want because they're battling an endocrine disorder that you can't overcome without help. It is, it's exhausting and it's demoralizing. So I just want to tell you that it doesn't have to be that way. We can treat your endocrine disorder, which is obesity, and we can get you better health outcomes.
Would bariatric surgery help someone with diabetes also?
Bariatric surgery is terrific for treating people with diabetes. The health outcomes that you can see if you come to us with diabetes and have bariatric surgery will vary kind of depending on how severe your diabetes is. If you're earlier on in your diabetes diagnosis, we think that we have a better impact on it. It's easier to reverse. But even for people who've had diabetes for a long time, even for people who are on high doses of insulin, we usually see very significant improvements. I have many patients who've come completely off of their diabetes medications. And I have many patients who've gone from very high doses of insulin, even needing multiple types of insulin, to very significantly reduced doses, even if they then just need once injection a day. I think it produces an incredible improvement in long-term health.
So I guess for my own education, just to clarify though, you know, what if I'm within normal weight, but I'm a type 1? Is there a difference between type 1, type 2? You know, so you know what I'm saying? So if I just have diabetes and I'm type 1, if I go get bariatric surgery, you know, I guess my question is, it's not a cure-all for all types of diabetes. Is that
right.
true?
That's right. That's a great thing to point out. Type 1 diabetics have diabetes for a totally different reason. They have diabetes because of an inherent issue in their pancreas. People with type 2 diabetes have developed insulin resistance, and that's the type of diabetes that bariatric surgery is particularly effective against. And one of the things that's great to know about this procedure and diabetes, and that just speaks further to what an endocrine disorder obesity is that when people have bariatric surgery, they come out of the operating room already with decreased need for medication. Like, it happens as you roll out the door of the operating room. You haven't lost any weight, but already your body just needs less insulin, it needs less medication, because this is an endocrine disorder that we treat in the operating room.
Okay, so I've gone through this surgery. What happens with all this excess skin I've got? Does the VA work with that too?
We do. So the VA has plastic surgeons who will do paniculectomies. And it's important to set expectations on this because the VA does not do aesthetic surgery. So we will not do abdominal wall reconstruction. Particularly, we won't do an abdominoplasty. So the way I explain it to patients is that if you have excess skin and it's below your belly button, they'll take that off. But any extra skin that's above your belly button is going to stay. The extra skin that hangs off your arms and your thighs, that's also going to stay. If you want any of that removed, then you have to go to a plastic surgeon. You'll have to pay for that yourself. But if you just want the extra skin that's dangling down below your belly button to be removed, to prevent rashes, to prevent bad smells, the VA will take that off for you. We wait until patients have achieved a weight plateau. They need to stay stable at that weight for 6 months, and they need to demonstrate that there's some problem with that extra skin, like they're getting rashes or having terrible smells there. But as long as they meet those markers, then they're able to have the extra skin removed.
So, as good as our show is, and I believe it's very good, I think we're probably more than scratching the surface here of the subject. But if I really want to delve deeper, where can I go?
So if a patient is interested in bariatric surgery, the first place to go is to talk to your primary care provider. Your primary care provider can tell you about the bariatric surgery program in your area. They are probably going to be thrilled to have you bring it up, because a lot of primary care providers, I think, are nervous to talk to patients about their weight. They know that patients have heard it a million times, and it develops this negative reaction in patients because patients have tried so hard for so long. So if a patient brings it up to their primary care provider, they can expect a really positive response. They will be referred to the bariatric surgery program at that point, and that's when they start down the road to the info session.
Well, Dr. Smith, thank you so much for being here. This has been extremely informative, a lot of great information, and we appreciate you coming here today to educate us on exactly what bariatric surgery is and what it can do for you.
Oh, it's my pleasure. Thank you so much for inviting me. It's such a delight to be here.
And for more information on bariatric surgery, make sure you check out the video description below. And for those who have served or are currently serving, thank you for your service. Hey folks, connecting with your benefits is our primary mission, and the SITREP is providing more options than ever.
Subscribe to our free email newsletter, subscribe to our audio podcast channel, or subscribe to our content on YouTube.
For details and links, check out the description below.